Welcome to Dental XP tonight. You're in for quite a treat. You really have one of the world leaders in regenerative dentistry presenting a webinar this evening, my friend, and really in many ways a mentor, colleague, and somebody who's assisted me in my learning curve with regenerative dentistry, Dr. Mike Picos. Mike is going to be speaking to you about really some of the trends in regenerative dentistry and a lot of the different biological modifiers and bioengineering concepts that are really cutting edge. So without further ado, Dr. Mike Picos.
Welcome to this Dental XP Alveolar Ridge Regenerative Strategies webinar, Autogenous Bone versus BMP2. I would like to give special thanks to Dental XP for providing such an outstanding dental educational venue, especially Maurice and Eddie Salama for their hard work in putting such an incredible resource of education together. I would also like to say just a few words with regard to the Ultimate Graft course that Maurice and I have been doing now for some 12 years. This is the sixth venture together as we partner in providing simultaneous discourse on hard and soft tissue grafting in Orlando this coming June at the Ritz-Carlton Hotel. We welcome all of you to sunny Florida. Bring your families and enjoy the summer. As is true for all of the lectures that I have given over the years, all the talks, it's important to share with my audience that none of these clinical images that I'm about to show you have been altered or manipulated. During this time together, I would like to cover this specific outline with regard to Alveolar Ridge Regenerative Strategies. We'll look first at the science of autogenous bone and RHBMP2. We'll then have some material with regard to sequential digital diagnostic protocols that I follow for all of my grafting cases. We'll then look at the meat of this discussion, which will certainly include a number of case studies, and finally some summary comments. Tissue engineering principles with regard to clinical relevance are interesting to say the least. This specific technology now has been with us for a number of years, and it centers on three main elements, simplistically: cells, a signal, and a matrix. Because natural tissue healing and tissue engineering require these three fundamental elements that must be present and must be working synergistically. If we look at the cells, for starters, we're looking primarily at the stem cells. These are pluripotential cells that are partially differentiated, and in bone regeneration, these cells will range from marrow cells to preosteoblasts and endosteal or even periosteal osteoblasts. The signal are the growth factors themselves, also termed cytokines. And as you see here, there are a number of growth factors that have been identified. And of course, for this discussion, we'll be zeroing in on BMP2. What these growth factors have in common is that they act on the external cell membrane receptors of a specific target cell that allows it in turn to stimulate an expression of a normal gene. And they actually have pleiotropic effects. In essence, these are effects that are occurring simultaneously, as we'll see. For starters, angiogenesis is one element or one effect of these growth factors. Also, target cell proliferation, specifically mitogenesis, as well as cell differentiation, which is key to these morphogens, and upregulation of normal cell functions. The matrix is the third element that's necessary for this tissue engineering concept to be effective. And the matrix is a scaffold or lattice work over which, or upon which the tissue is grown and over which cells will migrate. Now, from a biological perspective, these scaffolds are exposed collagen as well as specific cell adhesion molecules. In the plasma, we have fibrin and fibronectin, and in the platelets, we have vitronectin. Allografts and xenografts allow these growth factors to adhere to their surface as well. So, of course, many of us use these so-called fillers with a number of our grafts. Today's discussion, however, will zero in more on BMP2 and autogenous bone. Speaking of which, autogenous bone grafting actually represents the complete tissue engineering triangle, because as we see here, with regard to cells, we find this cellular component in the marrow, the matrix, and the mineral content, and of course the signals of the cells, the BMPs, the PDGFs, etc., that are in the non-collagenous portion of the bone mineral matrix. And as we all know, autogenous bone grafting has been utilized for many, many years within the dental profession, and of course the outcomes are very predictable, great documentation, and the quote-unquote gold standard of all graft materials is autogenous bone. However, it's possible to enhance one or more of the components of this triangle for even a better outcome. And we can upregulate the signal by adding specific growth factors directly to the graft. We also can upregulate the matrix, which can occur with, again, adding a number of materials like demineralized freeze-dried bone or non-demineralized freeze-dried allogeneic bone. And of course, together with the growth factors, we refer to these as composite grafts. We can also increase the cell component by increasing the number of stem cells in the graft, and this can be done a number of ways, by condensing the autogenous cancellous marrow either within a syringe or with a condenser, or compacting the graft with bone compactors. And finally, the cell component can be actually increased or improved upon by increasing the number of stem cells within the graft. So stem cell numbers can be increased purely by obtaining them, for example, from the posterior iliac crest. If we look at bone morphogenetic protein, specifically RHBMP2, it's certainly developed in a molecular biology laboratory, and the whole cell line is the Chinese hamster ovary, as we see here. And it goes through a series of processes that ultimately results in the lyophilization or freeze-drying of this particular protein, and it is then combined with sterile water. This white powder, which is the protein, is then reconstituted for approximately 5 minutes, and then applied to the carrier, or the matrix, in this case a cellulose sponge, a collagen sponge, that is then soaked for approximately minimum 15 minutes. This allows for protein binding within the sponge itself, and this collagen sponge, which is a type 1 bovine collagen material, is approximately 90% air. It is again allowed to soak for this minimum time frame, can be used up to approximately 2 hours at a time. And as we're showing here, I typically will combine it with a mineralized allograft. Here I'm showing it being mixed with minerals in a 50-50 ratio. I found out early in my learning curve, having worked on approximately 135 BMP cases now at 4.5 years, that a 20 to 30% volume mix of a particulate graft with the BMP is not adequate for maintaining overall space dimensions. So as many folks now have gravitated more to the 50-50 mix, this has provided a more stable graft combination and the graft result. 1.5 milligrams per cc is the concentration for all of the available kits that we can use. Graft volume is 0.7 cc's all the way to 8 cc's. And of course, the expense of this particular product is consistent and prorated accordingly to the amount of material that is used. There are a number of studies, randomized controlled clinical trials, multi-center, prospective, that are fabulous, read about. Most important point here, though, is to know that there's terrific backing for this good science for this particular technology. And in fact, there's FDA approval for sinus augmentation and alveolar ridge augmentation associated with extraction sockets. Now, this is on-label use. Now, that said, everything I will share with you during this webinar with regard to BMP2 is off-label. Does not mean that that's an illegal use of the technology, only means that there's not FDA approval. If we look specifically at the mechanism of BMP2, the in vitro studies have shown very nicely that there's a tremendous chemotactic migration of stem cells to the BMP2. And in fact, there's a binding, as we mentioned earlier, to specific receptors that in turn allows that cell type to differentiate ultimately into bone cells or osteoblasts. And of course, there's a great proliferation of these cells. All this is going on simultaneously, but most impressively is the differentiation that is induced by BMP2, because this particular protein is in fact termed a morphogen for this reason. It is the only morphogen that we have available to us with regard to our bone grafting work. And again, it's osteogenic. It forms bone de novo. By comparison, if we look at PRP, or PRGF, or PRF, all of these are mitogens, a different bird. So we've got this potent morphogen, which again will form bone de novo, and as a result allows us to utilize this particular product in such a way that we don't need to have autogenous bone for a number of our graft cases. In summary, we can see this mechanism of action shown here, and I want to point out that the maturation and remodeling element of this entire cycle is most important, because as we'll see, and I'll allude to more than a few times during this discussion, is that the bone density of this particular grafting protocol results, or I should say gives us a bone density of approximately D3 to D4 sometimes, but hovering at more D3 and sometimes D2, depending on host response and some other factors that we're not quite, familiar with at this point in time. I summarized a number of these concepts in an article that I had published earlier this year on tissue engineering and inside dentistry, and you're certainly welcome to look at this article for more of that information. As we look now at a diagnostic workup for these particular grafting cases, and this is true for all of my cases, and has been for some 8 years now, in using cone beam CT in a sequential digital diagnostic protocol fashion to evaluate all of my patients with regard to a number of parameters, one of them being assessing the horizontal and vertical dimension of the recipient site itself. And of course, that's what it's all about, is what type of defect are we dealing with? Is it horizontal only? Is it a combination defect, etc.? And we're also able to evaluate potential donor sites. If in fact we're looking at harvesting bone, especially ramus buccal shelf block bone, or even synthesis bone, it's great to have these sagittal cuts and appreciate whether we actually have adequate bone volume, not just in cortical thickness, but in bicortical dimension to quote-unquote safely harvest this bone without subjecting our patients to morbidity, specifically fractures, etc. And most importantly, of all the benefits, in my opinion, that this particular technology affords us, is a reduced surgical risk and complication scenario, where we can minimize these potential problems that can occur by understanding three-dimensionally what we're dealing with anatomically before we even touch our patient. Now, some considerations that I think are pertinent to this discussion before we continue involve specifically anatomy of our patient. The recipient site needs to be looked at critically, and again, as I've mentioned, this can only be done with cone beam CT. The extent of the defect, of course, must be appreciated up front, and in turn, the donor site for potential bone harvest. Not everyone is a candidate for a bone harvest, specifically ramus buccal shelf, even synthocyl, and therefore we may not be able to give our patient the option of block bone, at least from the mandible, depending on their presenting anatomy. Also, the age of the patient is a consideration for these particular grafts. Are we looking at autogenous? Are we looking at BMP2, for example, with some mesh? Well, the age of the patient can dictate many times which way we'll go. The older the patient, in general, the more apt to look at a non-autogenous site, generally speaking. Medical history, same thing. This specifically will deal with patients who have a number of medical concerns that may require a more minimal time for surgery. Therefore, a donor site may not be the best solution based on just medical history alone. So therefore, we may want to minimize our intraoperative time and therefore bypass the option of using autogenous bone. And of course, clinician and patient preference, this will depend on a banter, an interface back and forth, a dialogue between clinician and patient, and showing what options are available, and then discussing them in detail so that our patients can better understand the options afforded to them and then make a choice accordingly. And last but not least, the clinician's skill sets and experience play a huge role with regard to which direction to move. Of course, if clinician is not real comfortable, for example, harvesting a ramus buccal shelf block graft and utilizing this particular grafting protocol, then that would not even be an option for a patient. As we look at some clinical cases now, I will be able to share with you a number of advantages and disadvantages of using autogenous bone versus BMP2, depending again on a number of parameters as we'll discuss. As we look at the anterior maxilla, for example, this is a young 18-year-old patient. Catherine presented with congenitally missing maxillary lateral incisors, as you see here, relatively thin gingival biotype and a high smile line. Not great combination for optimal biology, if I might say, and certainly presents or creates a challenge for us, not just functionally but aesthetically as well. The zeroing in on the underlying bone, once again, these sagittal cuts from our cone beam CT allows us to appreciate that the defect is on the buccal, or I should say on the labial or facial, and not the palatal. Seeing that we have this type of defect, of course there's some options that we can look at, one of them being a guided bone regeneration approach. Another could be autogenous block bone, and we could even look at a third option that would require, or that would entail the involvement of growth factors with a mesh of different types that could be used as well. For cases like this, I will explain to my patient that we do have the option of autogenous bone that is my personal preference, meaning a ramus buccal shelf block graft, as we'll see, could be used very conveniently, very nicely, with minimal morbidity for a younger patient like this. But the patient would also be given an option of non-autogenous bone approaches. And again, as we work up all of our patients with minimally the software from our 9300 CareStream machine, we also use third-party software for a number of our cases, as you're seeing here. And as we see intraoperatively, I did in fact use mandibular block bone harvested from the ramus buccal shelf, sectioned into two pieces, and we're able to very nicely harvest this bone in a matter of 10 to 15 minutes maximum, and be able to have our recipient site prepared As you see, we can fixate our blocks conveniently, and the success rate of these grafts is very high, 90 percentile, as it should be if we're going to use any of these particular grafting protocols. And both myself and others have certainly shown over the years, and in my case, some 20 years now using mandibular block grafts, that the success rate is not just high in terms of, yes, the graft works, but the graft volume is maintained, most importantly, over time. And we've shown that both with horizontal and vertical augmentations. We also like to use a mineralized allograft along with a mitogen, in this case, PRGF. The PRGF allows for the graft to be handled very conveniently, applied to the graft site certainly, and allows for upregulation of VEGF, which if nothing else will certainly give us a very nice soft tissue healing effect, an accelerated wound healing of the soft tissue that is important certainly as well. And even using a collagen membrane over this block mineralized allograft complex is in order to increase the actual augmentation above and beyond just the block graft bone volume itself. And using a fibrin quad over everything as you see here with primary closure, our post-graft evaluation cone beam shows us great adaptation of both sites. And again, using third-party software, this is Simplant. These volumetric renderings allow us to appreciate once again the amount of bone volume increase that we have in the abutment crown complex. The implant abutment crown complex is shown here very nicely to simulate where the ideal location of the implant should be. And of course, on reentry, we are very minimally invasive with our approaches and have been for a number of years, where permucosal screw retrieval is done as you see. Surgical guides can be used for precision implant placement, and these small mini flaps, if you will, approaches to the sites allow us to contour our bone accordingly. And ultimately at a 3-year time frame, we see good papillary fill of our embrasure spaces as we would expect. And certainly from the literature, we're well versed with the point contact to crust of bone concepts, as well as the interproximal heights of bone concepts as well. The literature really shows us nicely from both Dennis Tarnow's work and Team Salama that we can get a very predictable result, even with this thin gingival biotype, with these types of augmentation cases, if they're prosthetically set up appropriately. Let's look at a little different situation. This is Victoria, 17 years old at the time, presents with a congenitally missing right lateral incisor. Here we have a little different twist, because as we're going to see, we have a deficiency not just on the labial, but also on the palatal aspect of this ridge. Now, we have some options here. If we look at this patient intraoperatively, this particular site, once again, we can appreciate the volume deficit on the facial, on the palatal, and we can certainly block graft both sites with transcortical screw fixation. We can also use a guided bone regeneration approach, or we can use a time mesh with some particular graft, potentially growth factor combination, which is in fact what I chose to do. So using, again, the BMP2 protein with mineralized allograft, once again in a 50-50 mix with this time mesh, 0.2 millimeters is the thickness that I've used from many years back, and then revisiting this entire concept some almost 5 years ago again. A number of articles in the literature over time, certainly Phil Boyne from the 90s. One big negative of using BMP2 is edema. And in the aesthetic zone especially, it can be problematic for some patients. I think it's most important that we explain to our patients in advance that 7 to even 10 days, there can be significant swelling, 2+ edema, and therefore to be aware of this and act accordingly in terms of their planning, meaning staying home, out of the public's eye. This edema is more of an osmolarity effect scenario, meaning it's refractory to any steroid use. It will not be effective in terms of using, again, a Medrol dose pack, NSAIDs, etc. So it's more of a waiting game than anything else. And 7 months is the time frame I typically wait for reentries on my BMP2 cases. As you see here, the negative here, disadvantage of using just titanium mesh in general, whether it's with BMP2 or not, is a reentry must be accomplished to remove the mesh, and of course soft tissue volume can decrease as well. But we see a very stable and predictable result, as you can see clinically and radiographically. We have an augmentation of some 8 millimeters. This is very predictable, as I have found, for these types of horizontal augmentations. And again, the 3D volumetric rendering allowing us in profile to appreciate where the mesh is and where the augmentation is as well. Our implant is placed, and a 1.5-year follow-up. This is post-prosthetic loading, as you see here, and the cortical plates are intact quite well. Moving on to a little different scenario, where here we have a patient that was involved in a motor vehicle accident, and when we see this type of presentation on a sagittal slice of our cone beam CT, we can certainly begin to appreciate that there is both a horizontal and a vertical defect, as we see here clinically. These cases, at least for me, don't lend themselves too quite well to using mandibular block autografts. I prefer to use some type of particulate mesh combination, and BMP2 is ideal for these cases, in my opinion, these three-dimensional defects, where as long as we maintain space. Remember now, the scaffold, the collagen sponge is a very poor matrix, a very poor scaffold, because it will collapse. So the importance of space maintenance with BMP2 is critical. And that's why titanium mesh has been used often, as we're going to see throughout my presentation. We'll be using 2 other types of meshes as well. But with regard to titanium, it's a very ideal space maintainer. It's very malleable. 0.2 millimeter allows us to mold this quite well to adapt to the defect, and it's biocompatible as well. Here, the BMP2 sponge, I will adapt it directly onto the wound site. As you see, the importance of holes, in other words, site preparation, decortication, to allow for good bone bleeders to occur, and therefore the BMP can act directly on these stem cells to attract them and begin the entire cascade of events. After applying the sponge both on the facial and on the palatal aspect of the defect, as you see here, I'm also then mixing it with the sponge, the sponge along with the mineralized allograft in that 50-50 combination, and then mesh overlay, as you see. And I do like to fixate on the palatal and the maxilla, excuse me, and on the facial as well, and of course the lingual for the mandibular arch, as we're going to see later. In this particular case, this tooth needed to be removed, and at 3 months' time, this is what we did, using a small connective tissue graft and some mineralized allograft mineros to allow for a combination of hard and soft tissue augmentation to make sure that we increase our tissue volume as well. And once again, at 7 months, we see the result from our CBCT sagittal slice. Unfortunately, mesh exposure can occur, and from the literature we know that it occurs anywhere from as small as actually 0%, as one of our Italian colleagues reported on, all the way to 51% that Patrick Lewis reported on. Von Arx in 96 reported a 50% exposure rate, and Prusos and Lozada 57%. But with Patrick Lewis's large case series, 44 patients, 45 sites, the average augmentation, or mean augmentation, was 13.7 millimeters, although there were a number of exposures. Again, 50% exposures. The good news, only 1 graft failure. So therefore, porous titanium mesh, quote unquote, tolerates exposure very well and gives predictable results, which is what we know. And one of the negatives of, again, using Time mesh is the exposure that can occur. If it occurs after approximately a 2-week time frame, one can be cautious and not be so concerned. As we go back here and see this particular exposure, this is relatively small. These can be nurtured with Paradex and just with hygiene and no real concerns. Prior to 2-week time frame, there's a high incidence of failures with these particular grafts, and section usually is problematic. So one needs to be very careful with surgical technique and making sure a number of other parameters are met with the use of titanium mesh. Here we are at 7 months reentry once again. Outstanding bone volume, taking a trephinated core of the BMP2 site. You can see we have a 99% vital bone core from this particular sample, as we would expect. Outstanding bone volume and density in this particular case, allowing us to place an implant in the BMP2 site and in the extraction site as well, as you're seeing here. Moving right along to the posterior maxilla, we now can appreciate that, yes, in fact, we can use autogenous bone for cases like this where the alveolar ridge is thin, or a mesh particulate graft complex of some type. And keeping in mind that we can use xenografts and allografts as particulate grafts for a number of these cases without using any growth factors or autogenous bone. However, or I should say without using any morphogens. A number of mitogens can be used, specifically PDGF. But again, this particular discussion, we're zeroing in more on the BMP2 morphogen. Looking at this patient, at that point in time, this was a case that was done prior to the availability of BMP2, and I would very typically use the ramus buccal shelf, as I did here, for cortical grafting for horizontal augmentation, along with mineralized allograft, and in this case PRGF is more of a sandwich graft, if you will. The particulate graft, PRGF, being directly on the cortical plate that had been perforated, decorticated, and then the block graft placed over that and fixated, as you see here. 4-month reentry, very predictable bone incorporation, allowing us to place implants as we see here. And in the left hemimaxilla anterior segment, I actually did a small GBR type approach protocol that allowed me to place the implants as you're seeing as well. And this, keep in mind, that this ramus buccal shelf block came from one side only. And this is a 5-year post-prosthetic loading follow-up. For stability of these block grafts, there's no question. Again, autogenous bone, we can take slices directly through these particular tooth sites. And as we see once again in our sagittal cuts at 5-year follow-up, we have outstanding maintenance of the buccal plates in all sites, including the pontic site, where as you see there's still a screw in place where I maintain that due to the ever so little block graft movement at time of implant placement. Moving along to a little different scenario, this is a case, one of 3 that I'll show you, that represents my attempt to use a resorbable mesh with BMP2 for our augmentation, thereby precluding any re-entry to remove the mesh as we would with titanium. Here we have a number 5 and 6 site that have some deficiencies, as you see here, and we're able to do our typical site preparation. But here we're using a little different technology where these poly-D-L lactic acid pins can be welded directly into the marrow of the recipient site, and using the mesh, which is a resorbable mesh that will hydrolyze in approximately 6 months. This particular mesh is a very interesting one to use. I've used it with a number of particulate grafts and mitogens, but in the last 2+ years have included the morphogen, BMP2, because there has been some discussion with regard to the pH of the breakdown or hydrolysis of this particular mesh and interfering with the effectiveness of BMP2. I've not seen this to date. and I have a pretty nice series of cases going, so they've not seen that to be an issue, at least at this point in time, and have found this particular approach to be a very good one to allow for horizontal augmentation. Gerhard Edelhout has shown nicely in the literature and with his own cases over the years using this craniofacial use to begin with, but its application to dentistry in such a very nice way that when we use it like this with a collagen membrane over it, we can maintain good stability of the graft itself. And here, just a different case with this is an edentulous maxillary arch where implants had been placed already, and they needed additionally 2 implants in the anterior segment, specifically in the cuspid region. And as you see here, relatively thin ridges, not even having to use the pins that are provided with this particular approach or protocol. One can use titanium screws and or tacks, but the key is that this mesh will maintain volume for the RHBMP2 particulate graft complex in such a way that it will allow it to begin its cascade of events, and the osteogenic element or capacity of the BMP2 can be expressed quite predictably. And here you see at 6 months, almost 7 months re-entry, still some remnants of the polydielectric acid mesh, but most importantly, the graft has been effectively turned over nicely. The bone graft is incorporated well. As you see with the arrows, we have the augmentation we need. And as I'm seeing so far and following these cases up, the longest now is about 3.5 years, or just over 3 years of post-functional load. With a number of applications, these graft volumes are maintaining themselves quite well under functional load. And still a third case here where augmentation was accomplished with simultaneous implant placement, again using the same concept, even using some titanium tacks to maintain this little shell of mesh with particulate graft BMP2 complex, composite graft if you will, and again getting a very stable result, very predictable one. Now if we look at the posterior maxilla in this particular patient, as you're going to see, this presents a different challenge because we have a sinus that is essentially fully pneumatized as well as a ridge deficiency. These combination cases lend themselves well to simultaneously grafting both the sinus and using one of several approaches for ridge augmentation, one of them being an on-lake graft, another an interpositional type graft. And when we have membrane perforations, as you see here, collagen membranes can be used, as I have used them now for approximately 18 plus years for repair of any of these types of perforations, whether they're small or completely torn membranes. It doesn't matter. We're able to stabilize these particular collagen membranes with external tack fixation and even internal tack fixation to create an entirely new sealing to the sinus to allow us to graft. And of course, as I mentioned, under considerations early on, operator experience plays a huge role with regard to the extent of what we're able to offer our patients, meaning what approach we can use, what approach we're comfortable with, etc. And in this particular instance, I chose to not just sinus graft, but also ridge aug using an interpositional type approach, where as you're seeing here, we're able to very carefully and meticulously separate this ridge with a combination of horizontal and vertical osteotomy created by both the Piezza surgical approach and fine osteotomes, and using an interpositional bone graft approach with BMP2 and mineralized allograft, and in this case, a high-density porous polyethylene membrane that doesn't, quote-unquote, need to be removed, but it is non-resorbable. So this puts us into a little bit different category of using meshes, titanium mesh being a mesh that needs to be removed and, of course, is non-resorbable. This is non-resorbable, but doesn't necessarily have to be removed. As we see here in this article in the Journal of Craniofacial Surgery, a very nice study, a rabbit study done, showing the particular application of this type of mesh for bone growth, bone augmentation. Now that said, I have personally experienced some complications from using this particular membrane, this mesh, and others have reported on this more recently. So it's one that needs to be used with caution. Here we see, again, cross-sectional slices of the entire ridge augmentation, starting anteriorly and finishing in the sinus grafted site and the most distal region in the E site. And you can see good graft incorporation, taking a core at the most distal site, and once again evaluating this histologically. We see nuclei within all these cells, and hence these osteocytes are alive and well, at least were prior to this core biopsy. So no question that we get good graft turnover, and therefore we're able to place our implants, as you see here, in a very predictable mode. And using resonance frequency technology, the ISQ numbers are very adequate for implant stabilization, mechanical stabilization at this point within this type of bone density, and we're able to obtain good implant placement in a non-submerged mode, as you're seeing with these healing abutments. Moving along to full arch reconstruction cases, these are ones that would typically be addressed with iliac crest bone grafts, for example, tibial grafts. This patient has been some 40 years without a full upper denture, opposing lower fixed, as you see, teeth, existing dentition, which one would assume that the upper arch would have way more atrophy than we're seeing. At any rate, surprisingly, the vertical dimension not affected so much. This is more of a horizontal augmentation with a slight vertical component. As we see with these volumetric renderings, once again with implant, we can appreciate the extent of this defect. And using a concept that Al Mattia and I coined some years back, digitally guided bone augmentation that we published on in this particular book chapter, we will take and literally via computer, of course, we can augment the site. In other words, a virtual bone graft, as you see with the post-DGVA model, which then allows us to preform our mesh and save some intraoperative time. This can all be done now with computer alone, and even the mesh fabrication doesn't need to be done by hand. Here we're exposing the ridge and, again, preparing it. Sinus grafts had already been done. This was a staged approach. And in this particular instance, I chose to go to the tibia for autogenous bone harvest. This is an outstanding source for marrow, and a number of publications, as you see here, have been existed in the literature. This is a very great source of marrow. We can obtain more marrow from one tibia than an anterior iliac crest, mixing it with a xenograft and mitogen, in this case PRGF, with good handling and soft tissue effects. We're able to secure our mesh in a very nice way and, of course, obtain soft tissue closure without tension. Very critical for all of our bone grafts, whether they're mesh particulate, composite, autogenous blocks, etc. These particular concepts must not be violated. These different surgical approaches must be consistent. Now that said, once again with mesh, at 4 months we're seeing a little bit of some exposure, and at 7 months, lo and behold, one would be, I think, appalled to look at this, and I will tell you at 6 months this mesh was not much different than the 4-month follow-up, but unfortunately this patient was seen by a young associate of my of a group that I normally deal with, the senior individual who was out of town at the time, and at any rate a liner was used in such a way that it hardened rather quickly and literally abraded the entire mesh. Well, without getting into a lot of detail for purposes of this discussion, I can only tell you that I was able to obtain let me back up. I was fortunate through our cone beam CT evaluation to know that we had adequate bone under even that exposure. which was good news. Of course, the bad news was, how do I get primary closure over that exposed mesh? Well, I did. And 4 months later, we're able to, as you say, at the 7-month mark, I was able to remove that mesh easily, of course, and place my implants in a submerged mode. And then finally, at 4 months time frame, of course, obliterating the vestibule, had to revisit using, in this case, a cellular dermis matrix, or Eloderm, and a vestibuloplasty application. And at 4 years, this barber denture complex is very stable. No question, again, autogenous bone works quite nicely. The negative, of course, is that there is some morbidity to the harvest of bone from the tibia, some early gait issues time to time, not typically, soreness, not so bad, minimal scarring, but still, again, a donor site is involved as opposed to using, for example, some growth factors. If we look at the anterior mandible, moving right along, we have, in this particular patient, some failing incisors, as you see here, compromised considerably. And I thought, well, why not use BMP2 here? We can mineralize allograft within the socket simultaneous, except for one small problem, as I found out, space maintenance being so important here, that I was a little cavalier with regard to, again, the amount of particulate graft used. And at 2 weeks, we're seeing this very important effect that we'll see time to time with BMP2. That's some real erythematous tissue consistent with the upregulation of VEGF that BMP2 does so well. However, at 2 months and even at 7 months, we're seeing a narrowing of this ridge, and not very good to be looking at this point in time. And I knew radiographically that there would be some issues with regard to alveolar width, so elected to still place the implants, as you see here, 3O diameter, but now have to regraft, and of course this regraft is one that is not going to be charged to the patient. So the learning curve can be expensive as well, but at any rate, the particulate graft BMP complex with the membrane mesh is used here. This again, this particular porous polyethylene, very dense material is used, and at 3 months, it looks almost like there's a neoplasm. The effect of this particular graft combination done with appropriate space maintenance is a very dramatic one, as you see. And in fact, this patient actually complained. He goes, "Doc, what's this bump, this ridge that I feel with my tongue?" Well, I explained to him that he grew quite a bit of bone, both facially and lingually. Very predictable when we maintain space with this particular morphogen. And here you see the before and the after of all 3 incisor sites. Our last series of cases, which there will be 3, will look at the posterior mandible and the advantages of autogenous bone versus BMP2 mesh. Here we have a horizontal deficiency for this particular patient in the bicuspid molar region, right side, as is evidenced by the sequential digital diagnostic workup. And most importantly, we're able to evaluate the donor site. I can't stress this enough, the importance of looking at the ramus buccal shelf area if in fact one wants to harvest bone from this site. It's not such a great idea to just assume that this transcortical distance will be adequate, let alone the actual cortical bone volume of that buccal plate. There are patients where this particular dimension is minimal, under 10 millimeters, hovering at 6 to 7 at times, and therefore would preclude any bone graft harvest with regard to potential morbidity of course, a fracture. Here, we can safely harvest a ramus buccal shelf block graft, as you're seeing, and I term this more or less a sliding block graft because it's very convenient to harvest it, and of course, being able to move it anteriorly in such a way. We have one wound site, and yes, there's morbidity from the harvest. It's equivalent to a third molar full bone impaction removal, and depending on the age of the patient, again, that's going to dictate many times which way we go, whether I will go with this block graft, as you're seeing here, in a sandwich mode with a mineralized allograft combination PRGF at the interface, and using the fibrin-clotted PRGF along with a collagen membrane. So we're using elements of guided bone regeneration now for some 5+ years in addition to our block grafts. And as you're seeing here at the 5-month mark, our sagittal slices through the 29, 30, and 31 sites, we have outstanding bone volume, great incorporation, and intraoperatively very impressive, because what I'm showing you here with the pickups on the right image is some remnants of the collagen membrane that you see on the left side before it was secured. And therefore, it certainly did its job by maintaining the particulate sandwich element between the block and the recipient bone, as you see from the left image to the right image. At 5 months, very predictable, very predictable. So an advantage of autogenous bone is a 5-month reentry versus the 7 months of BMP2. So from a time perspective, that's an advantage of autogenous bone. And here using a guided approach, where we place our implants in a very precision mode, and again testing them into this D2, almost D1, really quality bone, and that's another advantage of autogenous block bone, is we're certainly going to have a great bone density early on, as opposed to a BMP2 bone at 7 months will be less dense and will take time and will increase in density upon functional load, as we know from triplet study and others, especially the sinus augmentation study, that indicated and showed very nicely upon follow-up at 6 months post-prosthetic loading of the sinus grafted cases, the increased bone density actually surpassed that of the autogenous group. And here we see this patient completed prosthetically. We're able to evaluate again with cone beam CT at 1-year follow-up. Bone graft incorporation has maintained itself nicely. These buccal plates are intact very well. And seeing even the donor site, both pre-graft and at 1 year, we're looking at 1 millimeter difference at the same slice taken, or similar location, I should say. So proof of principle that yes, this remnant buccal shelf will remodel itself without any grafting to that donor site, and one can harvest another graft from that particular site at even 1 year out, post-graft harvest. So once again, an advantage of autogenous bone is the increased density and the fact that we are able to very predictably get these results in the high 90th percentile. Very good documentation by many individuals. Now let's just look at a different approach to the same problem. Here we have an edentulous left posterior mandible. The deficiency is in a horizontal dimension only, as I just showed you. However, what we'll look at doing is, and by the way, the donor site is evaluated, as always, and the patient can be given the option of which direction to go, an autogenous block graft, as I just showed you, or perhaps a mesh particulate growth factor approach. Well, due to the fact that this patient was in his 70s, a gentleman in his 70s, had some related medical issues as well, was felt mutually that it would be best not to really consider the option of autogenous block bone harvesting, and instead to use the mesh growth factor combination approach. And this is one that, again, I've done numerous times over the last almost 5 years with this particular protocol, and it's evolved over time, as has anything that we do. We keep making things ideally better, and fixation of this particular mesh will typically be done on the facial. These are self-threading, I should say self-tapping screws that are really nice to work with. We'll then load up our graft complex, as you see here, the BMP2 with Mineros and PRGF combination, and the mesh is then secured in place on the lingual. I do like to secure the lingual aspect of all of my mesh cases, be they titanium mesh, or the polyethylene, dense polyethylene porous mesh, or even the PDL or poly-DL lactic acid, the resorbable mesh. Same thing. They should be secured, I feel, on both facial and palatal aspects. So as you see here, we're able to get primary closure. A little bit of movement on this particular cone beam. As you can see, a little bit of blurring, but these are all between 9 to 10 millimeters of overall facial lingual or buccal lingual dimensions, indicating that we've gotten some great graft volume increase at 7 months. And our reentry, this is what we typically will see, a quote-unquote pseudoperiosteum that Phil Boyne coined many years ago. This is a kind of a fibrous tissue that I typically will leave in place, as you see here. And implants are placed. These are 4.6 millimeter diameter root forms with great bone volume, both facially and lingually, to allow for good long-term functional use without any worries of bone loss per se. And again, good primary closure. We'll need to be doing some attached, or I should say some soft tissue grafting to increase attached tissues in time. But certainly a very predictable re-entry, as we have seen time after time with this approach. Our last case, I will just show you and share with you that for vertical grafts in the posterior mandible, we can certainly look at block grafts as well. If we're looking at approximately 3 to 4 millimeters of augmentation, we can use a ramus buccal shelf block, as you see here. Another millimeter or so, we can use a particulate sandwich graft between the cortical block and the underlying recipient bone, or we can go with a mesh graft approach as well. Here, this is a 5-month follow-up with a ramus buccal shelf sliding block graft once again, taking the core, truffinating the distal screw, and being able to appreciate the amount of bone that forms even with these small screws during that time frame. And here's a 5-year follow-up with this particular case, vertical augmentation, great graft stability, and this is what we see typically with horizontal and vertical augmentations utilizing mandibular block grafts. However, that said, in the past, again, almost 5 years, the trend for me personally has been more using a mesh particulate graft combination, including BMP2, depending on the specifics of the case, as well as other growth factors, recombinant PDGF as well, with allografts and some xenografts as well. So that said, let's summarize some of the important elements of both autogenous bone as well as BMP2 for the cases that I've shown you, specifically alveolar ridge augmentation. Advantages of autogenous bone. Well, number one, the cost is certainly less than BMP2 because, of course, the patient's bone costs us nothing. There's decreased healing time, approximately 4 months on average. Occasionally can be a little bit more time, but not 7 months that I typically would wait for BMP2. And as well, the bone density early on and throughout the entire healing post that 4-month time frame is of a D2 quality bone, at times D1, especially using mandibular block grafts. Even with our marrow on reentries at a shorter time frame, we are typically getting a very good D2 quality bone. Also, what I'll consider quote-unquote normal edema will occur with autogenous bone grafts, meaning we don't see the excessive edema that we will see many times with BMP. And last but not least, the quote-unquote gold standard of autogenous bone, as it's referenced, it's well documented in the literature, a number of clinicians and great studies over the years using this type of bone for a number of grafting procedures. Disadvantages, of course, increased surgical time. If we're looking at a donor site, which we certainly need to have for these particular cases, then that's going to increase time of our particular case. Limited volume of bone is also a disadvantage. Depending on, again, where we're harvesting this bone, we will typically have a limitation, and donor morbidity is associated, of course, with any graft harvest, as one would expect. Looking at BMP2, in contrast, advantages decrease surgical time. So if in fact the medical history and or age of the patient lends itself to less time in and out in a more quicker fashion, less morbidity, therefore we can look at the BMP2 approach, and as I mentioned, no donor site, therefore less morbidity generally speaking, and no material limitation. Of course, we have to consider the cost element, but there's really an unlimited supply, technically speaking. Disadvantages of course, increased cost, as would be the converse of what we just talked about. And finally, in addition, increased healing time, a 7-month reentry versus a typical 4 or so month reentry with autogenous bone, and therefore accompanying this increased healing time is a decreased bone density, at least early on, as we've mentioned, because the 3-quality bone is not uncommon even at 7 months, depending on the graft size, the graft defect, and the amount of graft material that's going to be used for the case itself. And finally, last but not least, the edema issue is a disadvantage and must be once again explained to our patients very carefully. It is dose dependent. The greater the amount of BMP that's used, the more swelling that one can expect for sure. So in wrapping things up, I shared with you this particular slide on considerations early on. And once again, just to recap, the anatomy of the patient, how they present in terms of recipient site, specifically the defect. The nature of that defect is going to dictate which route we're going to go, be it autogenous bone versus BMP2. The donor site, again, if we don't even have adequate volume in the ramus, buccal shelf, or even symphysis, then that isn't even an option. Age of the patient, medical history, as we discussed, are factors. The clinician-patient preference, again, as we talked about. And last but not least, the clinician's skill sets and experience with these different surgical protocols. One must be very comfortable with using different approaches and different protocols for bone grafting in order to give our patients a good variety of options that can be used for their particular case. That said, I would like to give again special thanks to the Dental XP team for allowing this webinar to take place, and most importantly, for creating such an outstanding venue for continuing dental education that is appreciated globally. And of course, I'd like to thank my family for the time that they have given me to prepare for this webinar and the many other things that I do professionally. Thank you very much.
Mike, thank you for a wonderful and insightful presentation. That was really cutting edge. I don't think there was anything in regenerative dentistry that you didn't touch upon. And certainly I believe anybody who watched this evening understands why so many of us have such an immense amount of respect for you. A couple questions that were sent in by some of the viewers is, what are your thoughts on biologic modifiers? Obviously, you've been at the forefront for many years. Where do you see it currently? Where do you see it potentially in the future?
Well, no question, the role of biologics is really such an incredible one now for all of us. We have some tremendous opportunities to regenerate the hard and soft tissue in a different manner than we've been used to with certainly autogenous tissues. Having used now the mitogens for some 16, 17 years, PRP for about 10, 11 years, and in the last 7 years, PRGF. These mitogens have been very helpful primarily for soft tissue health in terms of being able to accelerate wound healing for a number of our cases from that perspective, using recombinant PDGF, although that was not my topic this evening. I do use that biotic modifier as well, and have had some great success with it. But of course, the potent morphogen, the BMP2, which I addressed this in this session, without question has changed the way I practice in terms of a movement, if you will, or a trend away from exclusively autogenous bone surgery to now using more biologics, and in the past 5 years especially. And as a result, I have some very, very excellent predictability in terms of what we can see case to case. And as so many of us are finding out, there is no black and white necessarily with a number of these cases that we do. But we do have choices time to time, and as I alluded to and specifically spelled out in my discussion, in my webinar, that there are certainly cases that will lend themselves better to using pure biologics, for example, versus autogenous bone, and vice versa. But as I see it, the trend, no question, is loud and clear, is that we'll be seeing more and more of tissue engineering elements in our practices, such that at some point in the future, we will not really need to look at autogenous bone per se at all.
That actually led me right into the second question, because really in a lot of ways you've been a pioneer in autogenous block grafting for many years, obviously with your institute and your lecturing around the world. Certainly for me, my entry into that area and getting confidence in doing autogenous blocks came from my interaction with you, and I couldn't thank you enough for that. Where do you see the role of autogenous block grafting now that with the advent of BMP2s and other mitogens and biologics that are out there?
Well, just in my practice alone in the past roughly 5 years, I would say, since using BMP2 as well as some of the mitogens I've referred to already, without question, I don't harvest as many block grafts for alveolar ridge augmentation as I did in the past. But again, as I spelled out in my webinar, the indications for autogenous block bone, for example, without question, there's pretty clear cut, at least for me. The posterior mandible, for example, horizontal augmentation, we have choices, as I already spelled out, the mesh particulates, whether it's BMP2 or even another bioactive modifier, versus the autogenous block bone. There's a difference in terms of timing for bone for reentry and bone incorporation, a time frame of 4 or 5 months for the block graft versus, say, 7 months for BMP2. And then, of course, that bone is not nearly as dense or the type 3 quality bone at that 7-month time frame versus the block graft. We can not only place our implants non-submerged, but many times we will immediately visualize these cases, and especially the posterior mandible. This is an example. The young lady I showed with the congenitally missing lateral incisors, a facial deficit only horizontal aspect. These are quote-unquote sort of slam dunks, again, for those individuals whose skill sets allow them to harvest a radius buccal shelf block graft with confidence. The morbidity is really rather low overall, and the benefits, again, 4-month reentry, implants placed, etc. So there's definitely some indications that will still allow the block bone to be utilized, not just for horizontal, but even some vertical augmentation cases. However, that said, the 3-dimensional cases, for sure, the 3D defects, as I see them, lend themselves best to BMP2, as well as implant repairs and grafting around implants that are placed in such a way that there still needs to be some augmentation. So simultaneous placement of the implants, more of almost a kind of a GBR type application, if you will, lends itself well to using again BMP2 for those cases. But overall, the trend for me, and I think in general for those that use autogenous bone, not just drop bone from the mandible, but even narrow harvests from the tibia, as well as bone from the iliac crest, without question the trends are decreasing in terms of using these autogenous bony sites for grafting. And the push now seems to be, the trend is without question more towards the biologics, and we'll be seeing more of that.
And Mike, how are you mixing the BMP? Just everybody seems to have a different cocktail. I know you alluded to it during your presentation, but there were some questions. And also, what type of mesh are you using? What is the size of the mesh, and what are the pore sizes of the mesh?
The combination of mineralized allograft, and I mentioned that Mineros is the graft that I've used, graft reserve for the past 6+ years. Before that was a different mineralized allograft was from 10, 11 years. I've just liked the results from mineralized allografts in general. And as a result, I do mix that particular graft with the BMP2 in roughly a 50-50 volume mix. The 20% that a number of clinicians have talked about and allude to with their respective works and cases, for me personally, it didn't work out early on. At least I didn't feel I got quite the volume. And as I increased the volume of the graft ultimately, as I increased the particular graft volume to 50% approximately, then things really started to click quite well. So it's a 50-50 mix. When I do use titanium mesh, it is a 0.2 millimeter thickness mesh, and we're able to obtain these now from a number of sources. In large pieces, we can cut them up and autoclave them, so cost per unit really is a nominal number. Pore size is not the most, not the micro, not the macro, almost more of a middle line pore size of about a millimeter plus. Has worked the best, although in my hands and most everybody from what I've seen and gleaned from the literature, all of these titanium mesh types will work well.
Well, that really kind of leads me from technique into the fact that any of the things that you showed this evening really require a certain skill set, surgical comfort and experience that comes with really significant training. Obviously, yours comes with significant years of experience having performed this, and obviously your oral maxillofacial training. We know you have an institute, obviously, as I said before, somebody that I've learned from already. Where do you see that role in terms of some of the presentations that you have and some of the things that you've done at the institute? Where would be the best place for somebody to start if they wanted to come and train with you? What would be some of the things that you would suggest to some of the viewers?
Well, up until just these past few months, for some 22 years now that I've had my institute, we've taught basically at an advanced level, both from the soft tissue grafting perspective, a separate course, soft tissue grafting for implant application, as well as 2 different bone grafting courses at an advanced level. We now have a separate track, a foundational track as we call it, that addresses the entry-level clinician for not just basic implant placement, but also into sites that are suboptimal, if you will, or have deficits or primarily horizontal defects to start. So there's a full-blown continuum that we have now to address pretty much every level that a clinician is at. I think most importantly that these courses are founded on science as well as the art, as we like to call it. It's an integration of the science and the art together in such a way that with the 29 years of work that I've devoted in this discipline of primarily implant-based surgical reconstruction, we have now protocols that have been proven and tried over the years, very predictable, that will allow a clinician to develop his or her skill sets ongoing. And of course, as is true for all of us, the CE element is one that continues as long as we practice, without question. So I think we're able to offer some very nice, will provide the means to challenge all the clinicians that are wanting to learn more and certainly be able to improve their knowledge base of the different regenerative procedures that we do.
There's no doubt. I'd like to remind those out there that what Mike showed tonight is really something that, as I said before, these products will work if you use them correctly and you have the right skill sets and you're able to manage the surgical areas with a high degree of effectiveness. But they also, no matter what you use, no matter how new the products are, no matter how engineered they are, those products will also fail if you don't have that skill set, if you're not able to manage flaps, if you're not able to manage proper suturing, proper release of the flaps, and of course managing complications. So you'll see right next to the presentation tonight, there is a banner, the PICOS Institute, that you can click on for further information about the courses that Mike puts on. There is a continuum, I would suggest, for, as Mike said, those who are just entering the field, and it really covers everything from diagnosis to cone-beam CT technologies, and then all the way through implant training to surgical training that you will need to implement them in your clinical practices. So please click on that link. You'll see that Mike tonight, actually, I wanted to not only thank him for the presentation, but to also compliment him and wish him much success. The background that you have tonight is the new PICOS Institute, which is brand new. It was opened just a few months ago, and it is absolutely state-of-the-art. It is beautiful. For those of you who haven't been there, it's really something that you would all want to go and see. So I just want to thank Mike again, and to, again, let all of you know that this type of interaction really comes with a lot of effort, and Mike was able to really showcase to you, I think, some of the most cutting-edge cases and materials and biologics that are available in the market tonight, and I'd like to thank him again. Mike, thank you very much for your presentation, your time.
And thank you, Maurice. Thank you very much.
You're very welcome.